Good morning. My name is Dorina Petrovsky, and I'm the Senior Chair of the Gerontological Societies of America Emerging Scholars and Professionals Organization Webinar Task Force. Along with Sierra Somerville and Megan McCutcheon, we would like to welcome you to this webinar, our 7th installment of the ESPO Professional Development Webinar Series. The title of this webinar is Culturally Adapting Interventions to Promote Healthy Aging Among Latinos, Best Practices in Research and Publishing. Our speaker, Dr. Adriana Perez, will explore relevant issues related to culturally adapting interventions in older Latinos. Dr. Perez is the Assistant Professor and Senior Fellow Leonard Davis Institute of Health Economics at the University of Pennsylvania School of Nursing. Her research is focused on theory-based interventions and environmental policies that promote physical activity and healthy aging in Latino diverse communities. Dr. Perez is a member of GSA and past chair of the GSA Policy Committee. We will allot around 15 minutes towards the end of the presentation for questions or discussion topics. You can type your questions through the control panel on your screen in the question box area at any time during the presentation. Thank you so much for joining us.
Good morning, everyone. I want to thank Dorina and the ESPO for this invitation. It is my pleasure and honor to speak with everyone today, and I'm looking forward to a lively discussion. I want to thank you also for your questions in advance. These are great. So let's get started. Next slide. To begin, thought it would be great to show this slide twice. So this is what I want to focus on and hopefully provide for you today an example of how one can demonstrate best practices in terms of finding the balance between culturally adapting an intervention and maintaining fidelity to intervention. So I'll talk more about that. But these are the 12 best practices that have been noted in the literature, and I have several references that I'll share throughout as well, because these are very helpful. There are several published papers that I always refer to when either working on applications or publications, and this one was the author for this is Backer from 2001. So next slide. Thank you. So in terms of my own research and the background of the problem, I look at how important it is to address issues related to the older Latino population. Here's some data from the Administration on Aging, which projects that between 2008 to 2030, the Latino population age 65 years plus will increase by 224% compared to 65% increase for the non-Latino white population in the same age category. As the population ages, Latinos experience a high risk of developing chronic diseases, including Alzheimer's and cognitive health and other dementias. And actually, my research now is including some cognitive health and mental health. But this is all, informed by my background in terms of cardiovascular disease. And as many of you know, many of these chronic conditions go hand in hand. So as we age, our risk for cardiovascular disease increases. And next slide. Of the major modifiable risk factors, physical inactivity has been found to affect the largest segments of the population, particularly those with lower socioeconomic status, older adults, women, and Latinos. Next slide. Ecological models of health behavior emphasize the environmental and policy context of behavior change while incorporating social and psychological influences. Ecological models lead to the explicit consideration of multiple levels of influence, thereby guiding the development of a more comprehensive intervention. Risk factors come from different types of systems, from those systems that are most proximal, for example, the family system, the peer system, school system, the neighborhood. All of these systems directly impact a person's health outcome. So social support, we know decades, or at least 2 decades of research that support the role of social support in keeping Latinos healthy, especially older Latinos. Next slide. The primary aim of cultural adaptation is to generate, next slide please, thank you. The primary aim of cultural adaptation is to generate the culturally equivalent version of a model or intervention program. So it is important to have a framework, a model to begin with as a foundation for your intervention. Next slide. Adaptation that is guided by a sound conceptual framework will aid in effectively resolving program consumer non-fit. Important dimensions to guide adaptation strategies include A, cognitive information processing characteristics such as language, age, developmental level. B, affective motivational characteristics as related to gender, ethnic background, religious background, socioeconomic status, and C, environmental characteristics that include ecological aspects of the local community. Cognitive informational adaptation is necessary when the current consumer group cannot understand the program's content. That is, content that is unclear or confusing to them. Translation from one language to another is obviously the most general form of program adaptation. Beyond conceptual equivalence is attaining cultural equivalence in translation. And this raises a greater challenge of establishing this equivalence by eliminating sources of cognitive and/or affective conflict or non-fit. So it's important that participants understand the content, and that content, again, is culturally equivalent to the concepts of your intervention. Next slide. So there are 2 basic forms of adaptation, and they involve modifying program content and modifying the form of program delivery. Modification of content may be necessary if a consumer group needs or wants certain programmatic content not offered by the original model or program. This content may be incorporated throughout the curriculum or manual. It may be designated as a complete supplemental module. So, for example, a module for coping with acculturation conflicts when, the mainstream culture really conflicts with a person's native culture. Form of delivery refers to presenting the same program content, albeit as delivered with changes in the characteristics of the delivery, the person delivering the intervention. Lay health workers or community health workers, promotoras de salud, are found to be very effective in certain communities. The channel of delivery, maybe an intervention could be delivered through the internet via web rather than school classroom, or for older adults, they can be delivered in the faith-based communities and churches. Location of delivery, as I said, community-based. Currently, my work has involved community health centers that are located within neighborhoods of the population that I'm targeting. Those have seemed to be offer a great opportunity for intervention, physical activity intervention delivery. Next slide. So I do want to spend a couple of minutes just describing this intervention. This intervention, and I'm sorry, the reference at the bottom there is a little bit cut off, but it's been developed with the original work of Dr. Julie Fleury at Arizona State University, and she developed the original model when looking at cardiovascular risk in older African American communities. And so being that this model had already been tested in underserved and among older adults, it provided a great launching point for my own research. And so what I did is an extensive review of the literature of interventions, existing interventions on the older Latino population. And what I found is that components identified as important through this literature review and also preliminary work, but not exclusive of data from phase 1 formative research, included, as you can see here, intervention strategies, social network support through community-based group interventions, empowering education focused on not just the risk of cardiovascular health, but also how we can create social and contextual resources, and enhancement of motivational skills and resources to promote behavioral change process. Through the mediating process, social network, you can see that social contextual resources are critical to achieving behavioral outcomes and health outcomes. And I wanted to share so far the health outcomes that I'm looking at. I'm currently doing some work with Dr. Nancy Hodgson and her intervention and adapting it to older Latinos. And she looks at palliative care, end-of-life care. And so health outcomes that I'm interested in include cognitive health and, still physical activity leading to cognitive health improvements in levels of depression, quality of life, at the same time, cardiovascular outcomes. So I will come back to the model and just sort of explain or provide some of the examples of my intervention. Next slide. The Fidelity-Adaptation Tension involves two competing aims. So you saw the model that I'm working with and have used. So those critical pieces, the critical inputs do not change. It's how they are implemented that would look different in a given population. So you still have to maintain fidelity. And so here I share that the competing aims are, one, to develop universal prevention interventions and implement them with fidelity and documenting how fidelity is captured, and to design prevention interventions that are responsive to the cultural needs of a local community. So there has to be that flexibility in the components that we identified, the dimensions that we identified. Next slide. So there are various ways, the methods in which to approach this, and I always now feel that I approach an intervention in a two-phased approach, using mixed methodology, integrating qualitative research as well as quantitative data, numeric scores, complementary forms of research evidence. And as I mentioned, you can gather this data throughout, concurrently or sequentially. Most of my work has included both, having a first phase approach where I collect qualitative data to ensure that the concepts are understandable, that the participants that I'm targeting understand them, that they apply. What can I learn about the local culture, the local community? And throughout the intervention, as I tape intervention sessions to capture any kind of relevant context when implementing the intervention. Next slide. And in the next few slides, I just briefly want to share, because I want to provide examples of my research. So here's the first aim. This is the first phase, in which I said in order to optimize the cultural relevance of a theory-based intervention and exploring that, the concepts of the intervention, which include motivational aspects, social and contextual resources. How do those look in the targeted population? And so here are some specific questions that I ask in focus groups what are the motivational factors, the social networks. I don't just look at barriers, but I'm very interested in community strengths, because you can build on those to initiate help, to promote behavior change, but also to sustain it. And then what are culturally relevant ways to foster physical activity and related cardiovascular health outcomes, finding out information about the acceptable forms of physical activity in a community among groups that you're targeting is important. I gave an example the other day in the discussion that there are a lot of current physical activity types of programs, Zumba, yoga, all, a lot of great emerging work in physical activity, but those are innovative forms of intervention research, but at the same time, they might not be acceptable to a group of older women, Hispanic, Latino women who are traditional, who are religious, who are modest, who, might prefer other forms of activity like gardening or dancing with their grandchildren, which I found many wanted instead to do things that they can do with their family and as part of their role of either being a grandmother, a caregiver. Next slide. And in the phase 2 of the intervention, then testing the efficacy of the model, wellness motivation intervention, in increasing resources, behavioral change process variables, and the behavioral outcomes, as well as the health outcomes. So here, hypothesized that participants would demonstrate significant increases in the social contextual resource variables process change compared with the attention control group, that they would demonstrate significant increases in physical activity, including frequency and duration, and that lastly, ultimately, we would see improvements in cardiovascular health outcomes compared to the attention control group. And next slide, and then finally, that we examine the process, that we look at how women received the intervention. I'm now including men in the work that I do and just sort of opening the intervention up to both men and women to see, mainly because actually that's what I learned from my original work, is that women wanted opportunities to bring their husband, their significant other, as part of that intervention. And so in the first trial that I had grandchildren, I had men, I had younger women, and so while my focus was the older Hispanic woman, the older Latina, I felt it was a missed opportunity not to look at outcomes in younger people and men that I think would have been very helpful. So in that third aim, bringing women back to find, I brought women back to find out how acceptable was the intervention as measured by an evaluation component that included their assessment of the protocol, the treatment components, the mode of delivery. Was the intervention feasible? And that can be measured through attrition rates, attendance at intervention sessions. Next slide. So again, going back to the model and reminding you of sort of what the strategies were, the mediating process, and what we hope to still achieve. So this model is shared with women in that phase 1, gathering information about what social support would look like in the community, what kinds of additional education we can embed as part of that empowerment process, and what other motivational support would be helpful. And what I found was that in this group, in this community, women were predominantly immigrant from Mexico and had lived anywhere from 5 to 20 years, so that time varied of living in the U.S., but that they all communicated through these motivational sayings or dichos that I then used to adapt our calendar. So they would have diaries to document physical activity, but we use those dichos, those motivational sayings, empowering sayings, in those diaries as a way to provide motivational support, because in that first phase, they shared what would be motivating for them. And so that might look different in younger Latina women. It might look different with men. So it's important to capture those aspects so that you can, again, culturally adapt your intervention. But you could see that the critical inputs are the same. And we could still look at that through fidelity checks. Next slide. And just some examples of social contextual influences. These originate within the individual or as part of the social, cultural, and physical environment. Teresa Huarbe out of UCSF did a lot of the original work that I cite in my research. Here, for example, I learned that in the review of literature and in my phase 1 work, women described an ongoing process of coming to terms with diet and physical activity, actually. And so decisions of social, culturally disempowering environment limited their options to promote health. Women in this study reported a lack of support, and they found support to be very important. So not having a supportive environment was limiting. And support could come from friends, neighbors, comadres, family members, co-workers, their significant other. So this was important in my research to really build up that social support network. And because this intervention is delivered in a group format, through the 12 weeks of the intervention, women have a real opportunity to strengthen that social support network with each other. And, because they live within the same neighborhood, they can really learn about each other, connect, find ways to be active together. Hispanic women have also reported challenges in maintaining physical activity as a result of competing roles and responsibilities. Now, this was, for me, was a key learning, because what I sometimes see with certain physical activity interventions is that, or just health promotion interventions, is that the message is, for you to take control of your health. And that is a conflicting message for older Latina women in my study, because they're never driven by doing things for themselves. In other words, they're motivated by their family, by their friends, by their church members. So to say, do it for yourself or take control of your own health, I found was not as acceptable as let's do it for the family, let's do it for our community. It's about the group. Were key learnings. So next slide. And then the behavioral change process variable is also key. This is reflected in ways in which individuals create and evaluate goals, establish standards and strategies for behavioral change, regulate and strengthen patterns that result in behavioral change. So this is a problem-solving phase. It involves self-knowledge, so making goals, doing sort of an inventory of our goals and our experience with physical activity. Motivation appraisal and self-regulation reflect that propensity to strive toward new goals and then move beyond those goals when you have achieved them. So these change over time. Self-knowledge provides context for meaning through which individuals acknowledge their hopes and fears for future health outcomes and facilitates the action of needed resources to achieve that health goal. Readiness to initiate behavior change involves motivation appraisal as intention formation for goal-directed behavior, which is related to personal beliefs, values. So what gets someone from, in this case, physical activity, from being sedentary to being active? And it truly, for me, has been finding out or walking through that exploration process of motivation, what gets to women's beliefs and values. Through self-regulation, goals are then transformed into personalized action. Self-regulation is guided by cultural practices, environmental and economic factors, and response to personal contextual cues such as family or community environment. And then in the next slide is we look at just action. So here, action occurs in response to those social contextual influences and behavioral change process variables. Next slide. And just to provide some more information of my own research is I want to share the design that I used. I talked a little bit about this already. First, in phase one was focus groups to provide a systematic description of that cultural meaning, the social contextual strengths and resources. I did this over a series of focus groups offering different times, different community sites for where women can come and share their feedback. Cultural, focus group data can provide information about cultural relevance as well as theoretical relevance. So I shared the concepts of the model that I use and then take those concepts based on the feedback that women give to then do concept mapping and how those concepts would look in this particular population, providing an opportunity to validate the measures we were looking at. So again, not only did the wellness motivation theory measures those that include self-knowledge, readiness to change, motivation, appraisal, and self-regulation, we translated them but ensured cultural equivalency through this process. Next slide. And then in the second phase, I tested the intervention. Pilot tested the intervention to, again, evaluate the acceptability and effects of the intervention. I used a randomized experimental design with repeated measures, looking at intervention group versus attention control group. Measurements occurred at 2 time points, at baseline and post-intervention at 12 weeks. Next slide. So the intervention is manualized, and it includes the critical inputs of the theory. And throughout the 12 weeks, you can see where those concepts fit into the different sessions and how we build strategies to address those. The intervention itself is 12 weeks, 1-hour sessions, and because the intervention has been translated to Spanish, it could be delivered in Spanish, it could be delivered in English and Spanish. There is a process evaluation form and an index of procedural consistency that the intervener checks off to ensure that concepts were delivered, but also the intervention sessions are taped to compare the delivery versus the evaluation and index of procedural consistency. So these are ways to, these are strategies that are used to ensure fidelity. One of the questions I had was about how to ensure fidelity, and so that is a way. I tape all of my sessions. I haven't seen, but I think there is a sort of percentage, like you should at least record 25% of your sessions. I haven't seen a citation for that. I think so. I've just taped all my sessions and ensured that those match up against these process evaluation forms. Next slide. And in terms of analysis, for phase 1, it's a qualitative content analysis designed to foster data codes, emergence of data categories, and this includes an iterative approach, looking at the literature, what's emerging in the literature, and doing a constant comparison with that includes data analysis and theoretical sensitivity. Next slide. And actually, I apologize. I missed AIM 2 and AIM 3 were included in that slide. And for that, I've used repeated measures for AIM-2 to look at changes over time. In other words, the magnitude of effect on social contextual resources, the behavioral change process variables, physical activity, and health outcomes, using repeated measures analysis of variance. And for AIM-3, the feasibility acceptability, you can use descriptive statistics for your analysis. And so here we are back to best practices. So finding the balance, there's a guide for program fidelity and adaptation. Again, this is published by Backer 2001 is a reference, and they describe 12 steps. And so whether you're working on developing your research, your intervention, but also in terms of publication, it's important to include those best practices. What did you find? What were the lessons learned? And so documenting the process is important. The 12 steps that are described are, first of all, acknowledging or realizing what that fidelity adaptation balance is, going into the community, gaining entree into the community to learn about the community concerns, reviewing a targeted program to determine fidelity adaptation issues. I gave one example. Maybe your intervention has to test a certain kind of physical activity, and maybe that's not appropriate or acceptable for older adults or adults of a certain age. Those things are needed. We need to know about those things up front. Examining the program's theory of change. And I, obviously do use a model of that looks at a theory of behavior change over time and its core components. Do they match up against what you're learning in your qualitative research as well as the review of your literature? Determine needed resources. Luckily, I speak Spanish. I'm bilingual, bicultural, so I feel I can navigate many of these issues. But if you don't have that capacity, it's important to look beyond at who can be part of the team. And approaches that I have seen and myself I have found to be very effective is using people from the community, so promotoras de salud or community health workers that are seen as leaders within the community. In fact, my research does include promotoras because while I am, Latina, speak Spanish, there's still a lot about the community, the local community, that I might not know. So having a leader, someone that is from the population, that is seen as a leader and a mentor, is helpful. Consulting with the program developer and building this into your budget, into your research, and thinking about available training for the team, for those that you recruit to be part of your team. How do you, what are your adaptation efforts? Having a clear process by which you're going to adapt and having that written out is helpful. So everyone, especially the person, the intervener, the one that's delivering the intervention, understands that is a very important process. And for me, I highlight involve the community because this I have found to be one of the most important aspects of coming into a community and offering an intervention. Since I moved from Arizona last year, it's work that takes time. But in the end, when you devote that time, your energy, your commitment to not just testing an intervention, but to truly being committed to the health of the community is something that has to be seen, that community members have to see from you, that you're not just dropping by to, do your research and then, that's it, that you actually are invested in improving the health of that community. So you have to integrate all prior steps, all of these steps into a plan, a written plan that everyone on the team knows, and sharing this, in that phase one group work, you can share what your plan is and what you're learning. And remember, you can always come back and throughout the process include qualitative methods by continuing to adapt certain aspects of your intervention. And then an ongoing analysis of fidelity, adaptation issues. What are things that must continue to be part of the intervention, because again, you want to, at the end, explain that this is the reason why the intervention worked. So you do have to have that balance. So these steps have to be conducted under a rigorous scientific testing and evaluation of the modified program. When you publish, that has to be explained, because others want to do the same work. How can others translate your work if they have very limited information of how this program was modified? And you also want to make sure that the program is effective as the original program is, the purpose of the program, and having this these strategies built into your work could be critical. And the last slide.
Thank you, Dr. Perez, for this wonderful presentation. I would encourage everybody who's listening to the webinar, please submit your questions under the question tab. And then to start, I have a couple of questions for you, Dr. Perez. The first question: how do you approach minority aging groups? What are some of the techniques in approaching senior centers?
Yes, that's a very good question. Very important question, because I've worked with doctoral students, research assistants, and first of all, you have to be present. And like I said, a challenge of this kind of research is that it takes time. As I mentioned, I just moved to Pennsylvania from Arizona a year and a half ago already, and I feel like now, after a year and a half, I have some really great connections and work that I've been able to launch since moving, and it's taken a lot, it's taken a year and a half, but it includes being present, and by that I mean looking at opportunities to attend programs, to see, and this is sort of that process of, what I see as an ethnographic approach, right? To being part of the culture. You spend time, if it's a community health center, and community health centers are great research sites. The few that I'm attending have senior programs, so they're perfect, and they are situated within a predominantly Latino Hispanic community, and and so I have come in, I've asked their board, I've made connections with their medical director, their pretty much their whole team. You want to meet the leaders of the center or the site where you hope to recruit from, and share your work. What I offered was, I just did a presentation of my work in Arizona, and I shared the approach that I like to use, which is a community-based participatory approach. And what I did was ask for opportunities to get to know their community, attend senior program sessions, attend community health worker sessions. So I don't come in, with here's an intervention, I want to test it here. It's, I want to get to know what the concerns are of the community. Remember, it's like, understand what are the community concerns, because you might have a well-intentioned intervention, but that community might be currently struggling with immigration issues, with some severe illness issues, poverty, so you have to know the context of that site. So I would say at first, just getting to know the community, making yourself available. I always say, if there are opportunities for me to come and do a session on heart health, and or come and do a session about healthy aging or about nursing. I love doing presentations to get young people to think about nursing. And for me, it's a way to get to know who I might recruit to be part of my team and get to know the other staff, get to know the team. I like to do presentations not just for the leadership team, but I always ask to do presentations for the nursing staff or the allied health staff, the CNAs or medical assistants, because ultimately you want everyone to know who you are, what your intentions are, and it takes that process of getting to know the site and the community.
Okay, thank you. We had another question, which is a little bit similar to the one you just answered, is what would you suggest for young researchers who may be looking to make some connections with a population they do not already have a relationship with?
Okay, so it's how I think, is that kind of like what I just answered, that getting to know. So let's say, actually I feel like I am going through this right now. The Latino population in Arizona looks different than the Latino population in Philadelphia and Pennsylvania. So I feel like I'm starting back with obviously knowledge and lessons that I've learned through my first research program, but now learning about the culture here in Philadelphia is a process. It's going to the sites where people that are popular. So what are community sites, whether it's a church, whether it's a community center, places that or events that people go to. I've learned about annual events here in Philadelphia that are very popular, that are part of the culture, that I make sure that I attend, make connections with those stakeholders. They're not always in health, but it could be nonprofit organizations, churches that draw the population that you're interested in. I think those are some good initial steps to just getting yourself immersed into the population that you're targeting to learn, and there are nuances of, even between subcultures. So it's good to be well informed, and before, especially like I said, before introducing your research or the fact that you have an intervention you want to test. I definitely would not start out with that suggestion or idea when you're just getting to know the community. In fact, here the partners that I'm establishing always share with me that they appreciate this approach. They said, no one's ever asked us what we think. It's always been a researcher coming in to tell us what they want. So just keep that in mind, and I think that not only will you create some great networks, but some perhaps long-term networks that you can consult with later. I mean, the networks I have in Arizona are still great networks for me, and I hope to one day be able to do a multi-site testing intervention. So I hope that answers your question.
Thank you so much. Once again, I want to encourage all the attendees to submit your questions via the question tab. Dr. Perez, you used both the terms Hispanic and Latino in your slides. Could you please talk a little bit about the difference between the identities or nomenclature, and how do you use their terminology with older adults who may identify as one but not the other?
Yes, very good. First of all, one error that I've made in my slides is that you do have to use one term and just stick with it. I always start out acknowledging that both of the terms exist. Even in my publications, I'll say, acknowledge that there's this, that there are these two terms, and, I will use this term. Basically, there, the Pew Research Center did. I don't have the year, but I know that they published a report. This was recently an article that I saw from 2012 where they talk about this report, and they reported that 33% of people that they polled preferred the term Hispanic, and that only 14% prefer the term Latino. And what I know about the two terms is that people that use the term Latino use it because it's a more inclusive term. In other words, it includes people from French, even some French connections. It's beyond certain countries, and includes people with Portuguese ancestries, like Brazilians. So Brazilians, for example, are Latinos, but they're not Hispanic. So Hispanic is a short, is a smaller, I guess, if you will, group. It's a term that's been used longer as well. So what you will find is that older Hispanics, older Latinos tend to like the term Hispanic better. It's a well-accepted term in that population. In the older population, younger people, again, tend to like the term Latino. People within, the article said that people within their 40-ish range prefer decided that Latino is a preferred term, and mostly because it can be, it's more inclusive. So I myself don't have a preference, but to the question, I do, when I work with a community, like to know what term they like, and that's the term that I will use. But I do use the terms interchangeably, just to acknowledge that there are both of those terms. I'm not tied to to just one of the terms. But there are people that are very adamant about one or the other, and it can get to be a pretty heated discussion.
Okay. Next question we had. Have you considered a women's only or men's only approach to the intergenerational physical activity programs you're developing? The comment was, sometimes the co-ed experience activities are not very well accepted in some Hispanic cultures. You've touched that a little bit on that in terms of how your intervention development progress. So can you talk a little more about it?
Yes. In my original work, I only focused on older Hispanic women, older Latinas, because of the research. And in fact, when you are proposing your research, whether it's for funding or for your dissertation, any kind of proposal, you have to have justification for your sample, for your population, who you're targeting. And I had a great background on why I was focused on women, because clinically, my research has been informed by my clinical experience, both as a nurse and a nurse practitioner, looking at the disparities that women experience when it comes to cardiovascular health, especially women that are 50 and older. So I provided great rationale for that. What I found in the process in the intervention that I tested is that in this particular neighborhood, the women wanted to be able to bring their husband or whoever, but many did bring their husband. So I think now, because the work that I'm proposing now, I'm including that preliminary work language as, here are things that I found, so that now what I'm proposing is informed by that work. So there has to be rationale for why women only or men only, or for both. And as long as you describe that in your background, in your proposal, what's part of your preliminary work, or the review of literature, or the description of the problem, as long as you have justification for that, I think it's great. So for my own work, which I think was what the question was about. Am I considering? Yeah, I've tested women only, and now I want to actually include grandchildren as well, because again, this this new phase is informed by what I've learned in this previous research.
Okay, thank you. Can you touch a little bit on sort of strategies in publishing this work? If you had any suggestions.
Yes. First of all, this is a lot of information, right? And so it is important in journals that you're targeting to. We obviously have to meet the word limit. Some journals do want that description, so sort of thick description, right, of what the process that you used, and especially if you're publishing and you're focused on the cultural adaptation of an intervention. I have published the framework itself and how the concepts are applied among older Latino women. I believe it's a 2009 publication on the wellness motivation concepts. So it is important. You might have a publication that is just focused on this aspect, but if not, the purpose of your publication is to describe the results, I would say having a paragraph about the approach that included cultural adaptation and steps briefly might be enough. But I do think it's important to have a publication based on the concepts and your approach and your theory, and that could be its own publication. At least you might get different responses from different researchers, but I have found that to be helpful, because then when you're publishing the results of your intervention, you can say, you can reference your work that has already been published, that is already describing these steps. But it's still good to cite. You used the Castro's reference for cultural adaptation, or you've used a socio-ecological framework to adapt. So having those citations is important, as well as a description of what you're doing and what were the steps that you followed to ensure both fidelity and cultural adaptation.
Okay, we're going to take a couple more questions, and then we're going to finish. You mentioned in your presentation this sort of dichotomy between what older women perceive sort of the goal of the intervention was. They wanted to do it for their family, versus of the interventions that I think of, they're more targeted towards oneself. So, sort of the betterment of one's own health. How do you pull together these sort of two different directions? And have you found this sort of tension between the two in your work?
I have not found the tension in my work at all, actually. And even as a practitioner, when I see patients, it's always starting out with what people, in this case, older Latino women, want for themselves. And again, if I'm going to, because I, in my belief, feel that we should all do it for yourself, do it for, that could be what works for me, but it doesn't work for everyone. There is published work on the Latino culture and the Hispanic culture, the Hispanic Latino culture, about elements that have been found to be consistent among the broader Latino population, including all the subcultures that include certain aspects of how the population, characteristics. So, for example, familismo. Familismo is a concept of the Hispanic Latino culture that is very important. So when you have an intervention that is just for the person, you might have limited positive effects because it goes against what that culture believes in. So for me, it's not a competing tension because I don't approach situations like that. So if your theory is about it is not inclusive that way, then again, kind of like what the guidelines said here, you're finding whether that theory is appropriate for this population. So that might be something that you learn, that this is a theory that is not culturally relevant. That's what we mean when we say, is the intervention culturally relevant? And you find that out ahead of time in that first phase, that iterative approach, because in the end, you might have a high dropout rate if you don't address those issues up front. I think it is a must to sort of, if you're whatever population you're targeting, to learn about through the literature, learn about what's been done already and what researchers have found are characteristics of the culture, and then again confirming that by having that qualitative, that mixed method approach to being able to learn from the community that you're targeting at the same time.
Okay, we're going to take one last question, and since we're close to being done, all of the unanswered questions that were being submitted we'll forward to Dr. Perez, and she might comment on them if she hasn't already in her presentation. So last question, how can we make sure that the interventions are equivalent? Probably meaning how are they equivalent, what sort of outcomes you look at in terms of adapting your interventions and then comparing it to maybe the original intended target.
It really is, it is through this process, that you have the model, in my case, a wellness motivation intervention that includes motivation appraisal as part of that approach. And yet, the concepts, the critical inputs of that intervention are intact. Motivation is delivered throughout the sessions, that motivation appraisal, self-knowledge, that those are all part of the process with the spin of the culture or the population that you're serving that motivate. You found out a lot about what motivation looks like for your population. In my case, I did learn so much about what motivated this particular community of older women. And one of the things I found out is that, again, motivation looked very different for them. They weren't motivated at all by things that, as a practitioner or researcher, I'm motivated by, like, seeing a better LDL level or seeing, clinical outcomes. They're motivated by being able to do things with their family and not be tired or not be short of breath, or being able to walk their grandchildren to school, because before, they didn't do that. And not many of them were at all motivated by losing weight, so for, again, BMI, the health outcomes that we're interested in and we have to show as scientists are not things that, motivate them so much, but they obviously knew about those outcomes because we're collecting data. And what was interesting is to share that data with them was confirming that, yes, because this intervention included cultural aspects of motivation and individual motivation, we were able to achieve these health outcomes. And this intervention has shown to result in really great, improved health outcomes when it comes to cardiovascular health. And so that's how you ensure that you have that equivalency, that women are reported satisfaction. This had really high acceptability rates among women. And yet, you also have great health outcomes.
Great. Thank you so much, Dr. Press. I wanted to thank our speaker, for her time and effort in preparing this webinar. And I wanted to thank our audience members for submitting your questions and attending. For those questions that we didn't get to, we'll ask Dr. Perez to comment on those later on. And as a reminder, the recording of this webinar will be available later on the GSA website for those of you who want to see it again. We hope you found this an educational, useful, and meaningful experience. Thank you very much.